I wait till Dr. Dr.
Okay.
Ganga finishes here?
Doctor, stream started, Doctor.
Okay. I'll share my screen.
We are live now, Doctor.
Okay. Just give me a minute. Okay. So good evening, colleagues. It gives me immense pleasure as a president of the Tamil Nadu Ophthalmic Association to welcome each and every one of you for this focused and enriching webinar on Orbit and Oculoplasty International Masterclass. Orbit and Oculoplasty represent a fascinating intersection of art and science, where precision meets aesthetics and where restoring structure often means restoring confidence and quality of life for our patients. Today's session brings together experts who have dedicated years to mastering this delicate specialty, and we are privileged to learn from their experience. At TNOA, our commitment has always been to nurture continuous learning and promote clinical excellence and support every ophthalmologist in their journey towards better patient care. This webinar is a reflection of that mission, concise, high quality, and clinically relevant. I thank our esteemed speakers, moderators, and the academic committee for sparing their time to share knowledge in today's program. And to all our participants, thank you for joining us and investing your time and advancing knowledge. So we'll go on to the next slide. So I'd like to introduce our moderator for this session, Dr. Senthil Nathan. Dr. Senthil did his oculoplasty and orbital surgery training at Shankar Nethralaya after his MS and a short fellowship training in advanced orbital surgery at Leicester Royal Infirmary. He has presented in many papers, videos, and conducted instruction courses on orbit and oculoplastic surgical techniques at TNOA, AOC, OPAI, and European meetings. He specializes in aesthetic surgery, orbital tumors, fracture surgery, lacrimal and lid surgery. He is a chairman and medical director of Ramana Eye Center, and he's also a visiting oculoplastic consultant at the Rajan Eye Care Hospital. Thank you, Dr. Senthil, for putting this program together. So next, I'd like to introduce the panelist, Dr. Usha Kim. I think she's a very familiar name amongst all the orbit and oculoplastic surgeons in the world. She's the head of oculoplasty and orbit oncology services at the Aravind Eye Hospital, Madurai. The department has become a center of excellence in the treatment of rare ocular conditions that have to do with trauma, congenital anomalies, and cancers of the eye. Dr. Usha's unit is also a preferred destination for training in orbit and oculoplasty, and she's also the past president of OPAI. Next, we have Dr. Nizar Sonam and Poonam, consultant and in charge ocular processes clinic at Shankar Nethralaya, Chennai. She has special interest in ocular trauma, orbital infections, management of thyroid eye disease, aesthetics, socket, and she has many publications to her name. Most importantly, I would like to emphasize her work on orbital mucormycosis during a COVID outbreak. Dr. Pratibha Devi Nivyan has finished her MBBS, DO, DNB, and also oculoplasty and PhD in thyroid eye disease. She's a medical director and head of orbit and oculoplasty, a cataract surgeon as well at MNI Hospital, and also the clinical champion for the Vision Eye Center projects. Dr. Yogeshwari is a professor and head of the Department of Orbit and Oculoplasty in RIOGOH, one of the oldest centers, probably the second eye hospital in the world. Her honors and awards include Best Doctor Award for the year 2021. She has several peer-reviewed publications to her credit, published a total of 16 journals, and also delivered several invited lectures. With these few words of introduction about the panelists, I'd like to thank each and every one of you for taking part in this webinar and enriching the knowledge of the general ophthalmologist. And over to Dr. Senthil for his introduction of the next speaker.
Thank you very much, madam. I again welcome all the speakers from all over the world for taking part in our meeting conducted by the Tamil Nadu Ophthalmic Association. And since we have many speakers who are actually traveling out of station today, we request all the speakers to stick to the time of 12 minutes, following which we'll have a short discussion for 3 minutes. The first speaker will be Dr. Vanessa from Malaysia, who's leading the oculoplastic services in the Island Hospital, Penang, Malaysia. She's one of the founding members and the past president of the Malaysian Society of Oculoplastic and Reconstructive Surgeons, and was also executive committee member of the APSOPRS from 2018 to 2024. It's a pleasure to welcome Vanessa to our meeting. Dr. Vanessa, you can start your talk now.
Thank you, Dr. Santil. It is a pleasure to be a part of this amazing webinar. Today, I'll be talking on my topic is dry eyes. So can you all see my
Yeah.
slides?
The slides are visible.
Okay. So as we know, watery eyes is a very common problem. To many of us, sometimes it can be a mundane problem, it can be a bit of a nuisance, but since it is a very common problem and it significantly impacts the patient's quality of life, it necessitates accurate assessment and management. So when we are managing a patient with watery eyes, basically there are just 3 points that we need to know. Is it due to excessive tear production or reflex hypersecretion? Is there any eyelid problem which is causing the tearing, or is there an impaired tear drainage? So by assessing the patient in a stepwise approach, we can quickly arrive at a diagnosis. So reflex tearing is when there's excessive tearing due to irritation, or it can be due to some eyelid problem which is causing the ocular surface disorder and tearing, or it can be actual obstruction of the tear drainage system. So we just need to differentiate these 3 factors when we are assessing a patient with dry eyes. So it's either the tap is running too fast, or there's a blockage in the tear obstruction. So basically, when we have this in our mind, it's very easy to kind of manage this problem. So the first step in the assessment of dry eyes is the history. Once we listen to the patient's history, you certainly have a bit of a clue as to what the problem is. So first we ask the patient onset and duration. How long is the problem for? Is it a constant problem? Is it intermittent? If it is an intermittent problem, it is more because of some kind of dry eye problem. As a certain in a windy environment, then you know it's more of a dry eye and hypersecretory problem. If it is unilateral, then you think it is more of a tear duct obstructive problem. If it's bilateral, it's more of ocular surface or reflex hypersecretion. Does the patient have any associated symptoms? If the patient has discharge along with the tearing, then you can think of a nasolacrimal duct obstruction. Does it have any symptoms of dry eyes? The patient, or whether she has a history of facial nerve palsy, which can be causing a pump failure and causing watery eyes. Has the patient had any prior ocular or eyelid surgery like blepharoplasties, which can cause ocular surface disorders in dry eyes, eye drops, glaucoma eye drops like latanoprost eye drops, and any glaucoma eye drops have a lot of preservatives which can cause punctal inflammation, ocular surface disorder. Does the patient have had any nasal or sinus surgery which can cause nasolacrimal duct obstruction? And does the patient have any systemic conditions like Sjogren's syndrome, Wegener's granulomatosis, which can actually cause more of a dry eye kind of disease? For the anatomy, we are all familiar with anatomy. The tears are produced by the lacrimal gland. They fall down the conjunctival sac, and then they go to the canaliculi, and they come out at the inferior meatus of the nose. So the first 3 steps are very important. External examination, followed by slit lamp examination, and the 3 diagnostic tests. So on external examination, you can have a quick look at the patient. If you can see an obvious entropion, that is before surgery, and this is after surgery, then you know that the patient has, because of the eyelid problem or an ectropion like this before and after surgery. Or if the patient has had some facial nerve palsy, then you can see, you know, there's asymmetry phase, and you know it is due to some pump failure that is causing the tearing. But however, I've had patients who had a combination of facial nerve palsy and also tear duct obstruction, and they needed a DCR. So in these cases, I also warn them that they have a facial nerve palsy, which is also causing the pump failure. So they might improve, but not 100% with the surgery. Or if this patient had eyelid surgery before, you can see an obvious lid retraction, which is causing her to be teary. And this is her resolution of symptoms after surgery. So a quick external examination gives a good clue as to what is causing the tearing. After that, after a quick external examination, we move on to the slit lamp examination, wherein this, as we are ophthalmologists, all of us are very clear with this. You can see whether they got inflamed pterygium or corneal ulcers or uveitis. This is very easy to pick up on a slit lamp examination. And you can see here the patient has eyelashes rubbing on the cornea, which you can see on slit lamp, which is called like an epiblepharon or trichiasis, which is actually a second row of misdirected eyelashes. So you can see in this video, the eyelashes, the trichiasis is rubbing against the eyeball and causing the patient to have reflex tearing. And these problems can easily be solved by just a simple lid split and cryotherapy to kill off the eyelash roots. So this is a patient with epiblephron causing the reflex tearing. Now, sometimes you have to be very meticulous in your slit line examination. Like this patient had an eyelash which was stuck in the punctum, which was causing a conjunctival aberration and which was causing her to have tearing. So once this eyelash was removed, the whole problem was solved. Sometimes you can have like mebominitis, like in this patient, which can cause reflex tearing. So we can have a quick look at the meibomian glands. This patient has such bad meibonitis, and you can see the secretions that are coming out as I press and express the meibomian glands. So this can cause dry eyes and also reflex tearing. Another patient with meibominitis, you can see such bad thick secretions which have caused her to have a reflex tearing and dry eyes. So all this we can assess very quickly over the slit lamp. Now it's very important to turn the eyelids and also check. For example, this patient, she had a cataract surgery. This is her right eyelid and this is left eyelid. The right eyelid was uneventful. After the left, the right cataract surgery was uneventful, but after the left cataract surgery, she had persistent tearing and corneal aberrations. And when I everted, I initially thought it was drug toxicity because of the post-cataract drugs. But since she recovered so well in the right eye, I was a bit suspicious. And when I turned the eyelid, you can see all these concretions that are like poking out and causing her to have discomfort. And I had to place a one bandage contact lens for her. And she was just 1 week post-op and she healed quite well after that. Sometimes like allergic conjunctivitis like this is cobblestone papillae, and this is after shin cord. This also can cause tearing. Like this is another patient who came to me for tearing, had seen multiple doctors, and then nobody could find the cause. When I turned the lateral fornix there, she had 2 pieces of glass stuck, which I had removed. So this also can cause tearing. Most people, when I've called up my colleagues who had actually referred this patient to me, and they said they turned the upper eyelids, but they forgot to check the lateral fornix. So this kind of small things can be missed out easily. So once we have ruled out the reflective part and the eyelid associated part, then if the patient has a very specific history of tearing with discharge, especially unilateral, then you think of an obstructive cause. So for example, this patient had an obvious dacrocystitis, and we had to do surgery for her. But unfortunately, even during surgery, we realized she has an abnormal lacrimal sac, and we sent for biopsy, and it came back as a multiforma. So sometimes even obstructive nasolacrimal duct obstruction might not be so simple as we think. And other causes of obstructive tear drainage problem could be punctal stenosis, in which case just a simple punctal snip with a perforated punctal plug, which I do quite often, and it works very well for these kind of patients. Now, there are other tests that we can do, like a fluorescent dye disappearance test and a Jones dye test. And in this case, a 2% fluorescent is placed in the conjunctival sac, and one assesses whether there's a good flow of the fluorescent. For example, this patient in the fluorescent dye disappearance test, you can see the fluorescent, the tears are flowing down the cheek, and he has an obvious obstruction. He had punctal stenosis, so we did a little bit of dilatation for him, and you can see his dye disappearance has improved. And we also do syringing quite often. When you think of an obstructive cause, you do the syringing, and this is what we need in a syringing set. The cannula is very important, it has to be blunt, not the sharp Rylecroft, which can actually damage the tear passage, the punctal probes and the punctal dilator. And then we do a syringing to see if the fluid passes through the tear drainage system into the throat, means it's a patent passage. If there's a reflux of tear through the upper punctum, then there is a common canalicular block. If there's a reflex of punctum through the same punctum, it could be a canalicular block. And if there's a reflex of the saline through the same punctum associated with discharge, then most likely it is a nasolacrimal duct block. And if the fluid can be felt in the throat, then it is a patent nasolacrimal duct. So hard stop, we can also do a probing to see if it's a hard stop means a nasolacrimal duct block, and a soft stop means a common canalicular block. So a quick, this is how syringing I do. I put local anesthetic drops, dilate the punctum, and the saline is passed. In a case there was no fluid coming out, you could feel the fluid in the throat. You can see there's no water, it's quite dry. That means the passage is patent. And in this case, you can see there's a lot of fluid that is reflexing out through the same punctum. So she had a nasolacrimal duct obstruction. And also I also did a probing and she had a hard stop. So I generally can pass a probe if you're still not sure, and then you can feel whether it's a hard stop or a soft stop. And then also if it's obstructive nasolacrimal duct obstruction and you want to embark on surgery, you can do a nasal endoscopy. It will be a good idea. And this is a patient that we did the DCR because she had a nasolacrimal duct obstruction. We diagnosed as a lacrimal duct obstruction. We did a DCR, but when we opened up the sac, there were clumps of concretions that were stuck in a sac, which was more like an actinomyces kind of concretions, which were actually mimicking her symptoms of nasolacrimal duct obstruction. But nasal endoscopy is a must if you're embarking on surgery. It gives a good idea of the nasal anatomy, if there's any abnormality in the nasal anatomy, such as a polyp or any growth. So once you have done and you kind of diagnosed that this is an obstructive nasolacrimal duct obstruction, then you can proceed further with dacrocystography or dacroscintography. But a more improved version will be a DCG with a CT scan, which combines a DCG with a CT, which gives a good relationship between the nasolacrimal drainage system and the surrounding soft tissue and bony structures can be identified one go. MRI can also be used and also CT scan if you're suspecting tumors and trauma. But MRI sometimes can take a longer and it can be a little bit difficult in children because of long duration. And of course, nasal endoscopy to see if there's any abnormality such as a polyp or deviated nasal septum, which can guide us during surgery. So this is a CT DCG. You can see that there's an obstruction, nasolacrimal duct obstruction. The dye is in the nasolacrimal sac, and here on the other side, the dye is flowing well. So once we have come at a diagnosis, then the management is easier because we generally for reflex secretion is more conservative or managing the dry eye symptoms and medical management, and surgical options are needed if there is an eyelid problem or if there is an obstructive problem causing the tearing. So in short, teary eyes needs a systematic stepwise approach. First is the history is very important. That gives us a rough idea. Then an external examination and a slit line examination helps us to rule out reflex causes of watery eyes, followed by which we can assess the tear drainage system. The punctum, syringing and probing will help us to diagnose whether it's an obstructive tear problem. And we need to use nasal endoscopy for obstructive cases especially if you're embarking on surgery, and also imaging is needed sometimes for obstructive cases. And once we arrive at a diagnosis, after all our stepwise approach, the management is according to the diagnosis. With that, I'd like to thank you all for your kind attention, and I'd like to welcome you all to our Malaysian Oculoplasty Congress next year, which is between 13 to 15 August. Thank you so much.
Thank you, Dr. Vanessa, for the excellent talk and for keeping up your time. Thank you so much. Now the panelists, do you have any questions for Dr. Vanessa, please?
Hello. Yes,
Hello.
Yes,
Yeah.
madam. Professor Yogeshwari, yeah.
Yes, that was a neat outline on how to assess the watery eyes. When do you actually suggest for imaging, madam? Is it done as a routine or only in those cases like already recurrent DCR, or what are the specific conditions where you go for imaging, madam?
Generally, if you suspect an obstructive water tear drainage problem, and generally if I'm embarking on surgery or I'm suspecting some tumor, I will quite often do a CT scan just as a pre-op assessment. It is more for an obstructive tear drainage problem, and especially if I'm embarking on surgery or I suspect some tumor or some soft tissue mass that needs to be ruled out.
Probably another indication.
Also in trauma cases, like if they have trauma and if they had some plate placed there, I need to make sure that there's no foreign body or plate that is stuck for DCR if I'm going to embark on surgery.
Yeah, excellent talk, ma'am.
Yes, Dr. Usha Kim has also joined us. Madam, do you have any comment to make now?
No, I was just about to say that trauma would be another indication where imaging is mandatory. And we may have to do, which I think Dr. Vanessa has mentioned already. So yeah, I just wanted to add that point.
Yeah, thank you, madam. Thank you so much. Actually, Dr. Usha Kim is joining us from Egypt. She's there on a personal visit. Thank you so much for joining us from Egypt, madam.
My pleasure, my pleasure.
Thank you, Dr. Vanessa, for the excellent talk. We'd like to invite the next speaker. Dr. Vanessa, can you stop sharing your screen, please? Thank you. Next speaker is going to be Dr. Joyce Burns. I have great pleasure in welcoming Dr. Joyce Burns, who is a consultant ophthalmologist and oculoplastic surgeon at the University Hospitals of Leicester. She's practicing in a tertiary referral center and does a large variety of lid and lacrimal surgeries with particular interest in periocular reconstructions and DCR in high-risk patients. She also runs the oculoprosthetic unit along with the UK National Artificial Eye Service, and she has taken part in many publications, including the Leicester Peripheral Field Test and the long-term outcomes after BCC excision based on histological subtypes. It's a pleasure to welcome Dr. Joyce Burns, who will be speaking to us on lid ptosis management. Dr. Joyce, please.
Thank you. Thank you very much for inviting me. I'm just going to share my screen.
Yeah, we can see your screen now.
Okay.
Yeah, that's right.
So my brief was to discuss the approach to the patient with ptosis. And so I'm going to take you on a bit of a whistle-stop tour how I would address this particular issue. Some of the photographs and images are patients of my own, and I'd be most grateful if you wouldn't copy them for any other purpose. Thanks. So our aim in assessing ptosis would be to, first of all, exclude any serious or life-threatening causes of ptosis, and then to understand the problem, both identifying what the patient is concerned about, but also actually looking at what the real problem is. And this will then inform any surgery that might be required. So you're going to always, in medicine, you start with the history, and in ptosis, you want to know how long have they had it, and does it vary from day to day or during the day? In particular, most involutional ptosis will get worse during the day, but if it varies significantly from day to day, you need to be thinking about other possible causes. It's also essential to ask about associated symptoms, such as double vision or pain on eye movements, and to establish if there's any history of facial trauma or surgery either to the face or the eyelids. And in some patients, they really can't tell you for sure whether they've had the ptosis all of their life or whether it's a recent onset and what exactly is the change that they've noticed. So a review of any old photographs can be very helpful. And then, of course, in all of ophthalmology, we want to know about contact lens wear, but this is particularly important in ptosis conditions. And then I have the 4 Ds that I would always ask for in patients with ptosis, and these are diplopia, dysarthria or dysphonia, dysphagia, and dyspnea. And these things are all symptoms that might indicate the patient might have myasthenia. And this is a really important condition not to miss because in the UK, at least, it's not managed by ophthalmologists, it's managed by neurologists. And also, some patients can do very badly. And about once a year, we get somebody who goes into myasthenic crisis, sometimes while they're waiting for the results of their investigations, which in the UK can take 6 to 8 weeks to be reported on the blood test. So it's always worthwhile warning the patient of any red flag symptoms along the line of the 4 Ds and ask them to report for medical assistance if that should happen. Other life-threatening causes of ptosis, of course, would be the third nerve palsy. An acute painful third nerve palsy would usually indicate you need to exclude a posterior communicating artery aneurysm. But in some patients, the acute palsy will be due to a stroke. In actual fact, in Leicester, we routinely do angiographic imaging in anybody presenting with an acute third palsy, whether or not they have pain and whether or not they have pupil involvement. And we've certainly picked up some painless third nerves that shouldn't have been an aneurysm and most definitely are an aneurysm. So this must always be considered. The third one would be an acute Horner's syndrome, which if it's painful, you'd be thinking about carotid dissection. And again, it's not ophthalmologists to manage this. You want to send them towards the vascular surgeons. But an acquired Horner's syndrome that is definitely new, but of a slightly slower onset, you want to think about lesions along the sympathetic pathway. And some of these might also be life-threatening conditions. And then the other one that's perhaps a little bit more relevant to the current audience would be consider malignant infiltration of the orbit. So in somebody presenting with a new onset ptosis, if there's lots of swelling and induration of the skin as in this photograph, then you would straight away be suspicious that there is a lesion there. And in this particular patient, she had a history of breast cancer. But actually, sometimes the only clue is that there's an asymmetry of levator function. And if somebody did not have a congenital ptosis and suddenly you find that the levator function is significantly different on the ptotic side, then it's important to consider whether there's a lesion infiltrating that levator that is the cause of the trouble. And in Leicester, we've picked up lymphoma, we've picked up the first presentation of breast carcinoma simply by noticing this kind of ptosis where there's asymmetry of levator function. So when you come to examine the patient presenting with ptosis, I would always encourage you to stand back and look at the whole patient and the whole face at the beginning. And look for abnormality or asymmetry in not just the eyelids, but look at the brow, look at the face, look at the function of the face, and in particular, look for evidence of spasm. It can be really subtle, but sometimes the patient presenting with ptosis has actually got an underlying hemifacial spasm or a blepharospasm, which is subtle in the degree of spasm, but the treatment would be Botox injections rather than putting them through any surgical procedure. At some point during your ptosis assessment, you need to examine the eye movements, and I would tend to do this before I start to touch the eyelids. And the presence of lid hangback in down gaze is extremely useful. So in these images, this is a child with a congenital ptosis on the left. When they look up, the lid on the left does not elevate. But when they look down, the lid on the left does not go down either. And this is because in the congenital ptosis, the levator is somewhat inelastic. And this increase in hangback on down gaze is a very useful sign that this is ptosis that's been there from birth. Again, if the patient has a serious fibrotic condition of the orbit, they might also present in this way, but without a history of congenital ptosis. And again, you would be suspicious about what's going on in that levator muscle. Then you're going to observe the eyelid itself, and you're going to look for any evidence of swelling or mass, particularly thinking about the lacrimal glands or anything that might be causing a mechanical ptosis. You want to note which is actually the most ptotic lid, because occasionally the patient will complain about one eyelid, and when you look, you feel it might be the other eyelid. You want to notice the lid curvature and the amount of lid show and the position of the skin crease, particularly an elevated skin crease in levator dehiscence. And you want to consider whether there may be underlying proptosis or indeed a pseudotosis due to an enophthalmos. So this patient, for example, could have presented with a ptosis, but in actual fact, you can see that he's got a right enophthalmos, which is giving an increased lid show on the right. And this is not a ptosis at all. It's due to his enophthalmos secondary to silent sinus syndrome. In this patient, he was referred with ptosis, but the problem, of course, is not the eyelid itself. Even though there appears to be increased eyelid show on the left, he's got a brow ptosis on the right. And he's also got a right lower lid ptosis. And you would be considering whether this could be a facial palsy in this case. Now, in Herring's law, this is a understanding that there is a yoked innervation of the right and left levator, such that the same amount of stimulation is sent along the nerves to the levator muscle. And if you have a ptotic muscle on one side, you'll tend to get an over elevation of the opposite side because of that. So in this photograph, the patient has a left ptosis, but when you elevate that left ptosis, removing the need for that extra stimulation, it then reveals there's also a right ptosis, albeit a little milder. There are other things you might want to look for during your examination of Cogan's twitch, which is not exclusively seen in, but commonly seen in myasthenia. And this is demonstrated by asking the patient to look down for 10 to 15 seconds and then examining the eyelid as they look up. And in myasthenia, you tend to get a slight overcorrection of that lid position before it resumes the natural position in primary gaze. In these patients, you sometimes also see a lid hopping when they look from side to side for a similar reason. In patients with jaw winking, they're usually patients who have a congenital ptosis or occasionally an aberrant regeneration after a facial palsy, whereby certain movements of the mouth, the jaw, or the lips will give a change in the eyelid position. And these need managing in a rather different way to a conventional ptosis management. In everybody, you're going to look at the pupil size, and if you see an isochoria, you want to check which is the abnormal one. Decide for yourself whether it's the one that's too big or the one that's too small. And if you see a small pupil with heterochromia, then consider that the patient may have a congenital Horner's syndrome. In everybody where you're planning to do any kind of ptosis surgery, you also want to be sure you've checked for any degree of lagophthalmos and the presence or absence of a Bell's phenomenon, because both of these things will affect the outcome of the surgery in terms of the patient's symptoms. When it comes to measuring the eyelids, I've got my own particular way of doing it, and I would always want to use a see-through ruler so that you can check the contour of the eyelid and check that you're measuring from the highest position. You want to get the patient to remove their contact lenses and relax and sit directly opposite you, looking at the bridge of your nose. So in this case, you're going to record a number of things. The first one would be the palpable aperture or palpable fissure height, which is the distance between top and bottom eyelid. And the average for a Caucasian eyelid is around about 8 to 10 millimeters. Then we would measure what we call the margin reflex distance. And from the upper lid to the pupil reflex is the MRD1. And from the pupil reflex to the lower lid is the MRD2. And the sum of these should equal the palpable aperture or palpable fissure height. In some patients, either with lid retraction or with a lower lid position due to malar hyperplasia, that's a shallow cheekbone, you might get a degree of inferior scleral show. And I find that useful to make a note of because I would want, if I wrote down these measurements of the aperture, the MRD, and the inferior scleral show, somebody could draw me an exact picture of what the eyelid would, the eyelids and the eyeball would look like without actually seeing a photograph. And then, of course, the skin crease height will indicate whether there may be levator dehiscence, but it will also give you a position for any external surgery approach that you might choose to use. Measuring levator function does take a little bit of practice. Excuse me. You're going to you want to be sure that the brow isn't involved in elevating the eyelid. So you fix the brow with your thumb while the patient is looking in the primary position. And then you would ask the patient to look down and place your ruler, see-through, in line with the lid margin. And whilst you're holding the ruler still and the brow still, you then ask the patient to look up and record the excursion of the eyelid up the ruler. And in most patients, you need to repeat it 2 or 3 times to make sure that you've not moved the ruler as they're looking up. So in this picture, you can see on the top left that the patient is looking down and we've aligned the ruler with the lid margin. And then she looks up and you look at the excursion of the eyelid and you see that she has a levator function of around about 17 millimeters. Measuring dermatochalasis, lots of people have their own particular way of doing this. And I always want, if I'm planning to do blepharoplasty, to bear in mind that in most certainly in the UK, most women have plucked their eyebrows at some time in the past. And if you're planning to do blepharoplasty, you need to take account of where the eyebrow would have been had they not plucked it. But primarily, you want to measure the margin and to the brow in the primary position, and then gently unfolding all the folds of the skin in the eyelid, you measure from the bottom edge of the brow to the eyelid edge when they're looking down. Measuring brow ptosis, again, a little bit challenging, and people have their own ways of doing it. So I would choose something along the brow that there's a similar feature on the 2 sides that I could repeat. In this case, I've chosen the lower border of the eyebrow, and then I'm going to look at the lower border of the ptotic brow and measure the difference between the 2. And this would give you your measurement of the amount of drop on the brow on that side and might indicate what degree of surgery you're going to do. Additional tests required in ptosis assessment, of course, if you suspect enophthalmos or proptosis, you want to undertake exophthalmometry. And the visual field test is required in most health economies to demonstrate that there is a field defect responsible, caused by the ptosis, so that they can have funding to get surgery undertaken. In the past, we designed a specific field test for ptosis and dermatochalasis in Leicester, which was extremely useful and used all over the world. But unfortunately, Zeiss have redesigned their Humphrey Fields machines and they are no longer programmable for our test. So we tend to use the 30-2 field now. Additional tests you might consider if you suspect myasthenia would be the fatigability test, whereby you would ask a patient to look upwards, fixing a point on the ceiling for 2 minutes, and then resume primary position and look for a 2 millimeter difference in the lid position. So the lid position deteriorating after 2 minutes. The ice pack test is almost opposite. You would apply ice to the eyelid for 2 minutes and then recheck the lid position. And if it's improved by 2 millimeters or more, then that would also indicate a possibility of myasthenia. The phenylephrine test is used to look for the effect of doing Muller's resection by whatever technique you choose. And the recommended dose is 1 drop of 2.5% phenylephrine into the affected eye and remeasure the eyelid position after 5 or, according to some authorities, 10 minutes. And then if there's a difference of more than 2 millimeters, this is useful to note. It can occasionally reveal a unsuspected dermatochalasis as well. In patients where the pupil dilatation and blurred vision that ensued would be a problem, you can use aproclonidine 0.5% instead of the phenylephrine. And of course, don't forget to get the patient on the slit lamp, have a good look at the lid margin and the ocular surface. And my previous speaker has dealt with that beautifully. And a lot of the conditions that she referred to will also be responsible for ptosis. Similarly, tear film assessment may cause difficulties with keeping the eyes open effectively, and a dry eye will certainly be significantly worse after you've lifted the lid and increased the surface area. And then last but absolutely not least, always look under the eyelid. In patients who are contact lens wearers, you may see something like this, which is giant papillary conjunctivitis that might cause a mechanical ptosis. But just occasionally, you get a horrible surprise like this, which was one of the biggest melanomas I've seen on an eyelid. So yeah, always have a look underneath. Thank you very much.
Well, thank you, Dr. Joyce. Thank you for the excellent presentation. Does the panel have any questions for Dr. Joyce, please?
Dr. Joyce, it was a very elaborate and a very nice presentation. And just to add a few, you very well elaborated that good external examination is very mandatory. And the lid examination, if we see a papery skin or the cigarette paper skin, what they classically say, it gives a clue that the patient has got recurrent inflammation in the lid, and that's due to blepharochalasis. And
Yes.
the lid crease is very important. If the lid crease is higher up, and then we know that the patient probably has a disinsertion of the levator, so our management can vary based on that. And yes, the eversion. I practically had a very bad experience, and that was a learning experience for me as well. I thought it was an aponeurotic ptosis. I didn't double evert. I didn't do a double eversion. On table, I found something coming out from inside, and I had published that there was a fungal mass inside, a small fungal mass, and that was the cause for ptosis. And so double eversion of the lid, and more importantly, we can even do a double eversion to check if there is nothing under the lid, and that is very important. And ptosis, you mentioned about the hangback, that indicates a congenital ptosis. Similarly, more drooping on down gaze is a very classical picture of an aponeurotic ptosis. You covered everything else, Dr. Joyce. It was a very nice presentation to go through. Thank you so much.
Thank you.
Thank you, Dr. Pratibha. Dr. Joyce, I just have one question for you. Do you have any experience with the frontalis flap surgery for congenital ptosis?
Sadly, no, not yet. It's something that's just becoming more common in the UK. I have some colleagues in adjacent hospitals doing it. We are beginning to look at it in Leicester. But I think there's a lot of learning to be done. And I've seen 1 or 2 post-op cases. Some have looked wonderful, some not so wonderful. But no, I haven't personally done it.
Okay. And for Marcus ptosis, do you do bilateral slings or do you do unilateral?
Do you know what? I generally try and persuade them not to have anything, because a lot of them do improve with age. But if they do have a significant Marcus gun problem, I'd do bilateral.
Well, so you cut the normal muscle also and put in a sling, is it?
Because it's difficult to get it right otherwise, yes.
Okay, yeah. Thank you so much. Thank you for being here. Thank you.
Thank you.
Sir, can I
Thank
ask
you very much.
one question?
Sendel, one
Yes,
word.
yes, madam.
Yeah, so I think this controversy about bilateral or unilateral is going to be there forever. Ideally, I think ideally it's what the surgeon prefers and what the patient would prefer, I would say. I think the counseling is more important here, and the expected outcomes are based on what the patient and the surgeon is comfortable with.
Yeah, absolutely.
As there are all the legends here in oculoplasty, I have one practical difficulty in many of the moderate ptosis. Sometimes when we do levator, we do find the levator infiltrated with fat. I want the senior's opinion, like when we see fat in the levator, what difference should we do? Because then post-operative, I find there is some slight undercorrection, or I might have to do it again. So what do you people do for such cases when you see fatty infiltrated levator? Can you please? guide me in that.
Yeah, Dr. Joyce, please.
Yes, so for me, I would agree. I think if there is a very fatty levator, I presume they tend to look undercorrected because the stitches slip through the fat. So I would deliberately tend to try and overcorrect them slightly. Occasionally, if I think the fat looks a bit unusual, I might send a biopsy as well. But I do always note and record in the notes if I find a very fatty levator, as it does seem to indicate that they might have problems in the future. And if you have to go back in, it's even harder to understand what the anatomy is if they've had a fatty levator. So yeah, I would agree. I think they're much more likely to drop down, and I do tend to overcorrect them slightly.
Yeah, thank you, Dr. Joyce. Thank you, panel. And I would like to invite our next speaker, who is going to be Dr. Raghavan Sampath. Dr. Raghavan Sampath is a very leading oculoplastic consultant in the UK. He is an honorary associate professor at the University Hospital of Leicester since 2000. He runs a very hugely popular fellowship program at the Leicester University Hospital, and he has done his fellowship himself at the Manchester and Moorfields hospitals under the legends like Richard Collins and Jeff Rose. And he has many innovations to his credit. He is the founder of the Leicester Chopper for cataract surgery. He has played a huge part in developing the Leicester visual field testing for upper eyelid pathology. And he has also described the Leicester suture technique for low eyelid tarsal the Leicester lasso technique for lateral canthus fixation. And all these have made a huge difference in our surgical practice nowadays. And he is also one of the very few ophthalmologists in the UK to have a group private practice. He runs the Stonygate Eye Hospital since 2011, and he has also trained more than 40 ophthalmologists, oculoplastic surgeons who all gone ahead to become consultant ophthalmic surgeons in the UK, including teaching hospitals as well. And it's always a pleasure to invite Dr. Raghavan Sampath, who's also trained me, by the way. And it's a pleasure to hear him speak. Dr. Raghavan Sampath, it's all yours now. We can see your screen.
Thank you.
You can start your talk. Thank you.
Can you hear me and can you see all the slides? Thank you.
Yeah, we can. Yeah.
Right. I'll try to do a whistle top tour. Thanks for Joyce for giving me this particular slide. There are various types of exophthalmometers when you're assessing proptosis. So you need to be careful which one you use and make sure you use the same one every time you see the patient. And exophthalmometer is useful, but not perfect. So it's very variable when you see the patient. So it's more useful to look at the patient from all directions to see whether the patient has got proptosis or not. We all know all the causes of proptosis. Thyroid is common in our practice, followed by orbital tumors. Either could be intraconal, extraconal. So the proptosis can be axial or in a different directions. But do not forget there are other conditions which can present as proptosis. Could be myopia, contralateral enophthalmos, contralateral microphthalmos, which could be missed. What are the orbital tumors which can present? Orbit has everything in it. So anything and everything can present as orbital neoplasia. So could be neurogenic, it could be lymphoproliferative, vascular lesion, secondaries in the orbit, mesenchymal tumors, lacrimal gland, and do not forget the metastatic. And also we need to add paraneoplastic. Again, this is it doesn't follow the perfect pattern, as we all know, but generally speaking, anterior could be lymphoproliferative, mid could be mesenchymal or neurogenic, and posterior could be neurogenic, mesenchymal, or vascular. And you can see a patient here who presents with originally watery eye, but you know it's not watery eye. You can see the medial canthal lesion. You can see the globe pushed up. There's possibly a bit of proptosis. And you can see the tiny vascular lesion, which is a dentist. He had a visual field defect, and we managed to get it out for him. As you can see, the more the posterior in the orbit, more difficult it is and higher the risks. Neurogenic, it could be neurofibroma. We see more schwannomas than neurofibromas. And then in the optic nerve itself, you could have a meningioma or a glioma. Here is the schwannoma, typical presentation. And it could be spreading into the orbit. You should need to be careful, a meningioma especially. Vascular lesions could be cavernous hemangioma, capillary hemangioma, originally known as varix. It can cause slow flow arteriovenous abnormality and other arteriovenous malformation. This is a typical presentation of a lymphangioma, a child with a subconjunctival hemorrhage following a bout of cold and cough, and chocolate cyst, typical presentation. We tend to, first couple of episodes, we don't do anything. Beyond that, they go in for intralesional injection. Here is an unfortunate patient, lymphangioma with terrible proptosis and corneal abscess, and she lost the eye eventually. Capillary hemangioma can present like this, but a suture through the lower lid and a bit of pressure sorts the patient out. And this is the cavernous hemangioma, typical presentation. And do not forget, there is other tumors can present. Here is a yellow lid sign, which we described a while back. A patient with Wegener's, originally known as Wegener's, now known as GPA, because Wegener was associated with Nazi rule. Here is a patient with immunosuppressed. Immunosuppressed patient are a gold mine for a lid, lacrimal, and orbit surgeon. They get all sorts of tumors in and around the orbit, from squamous cell carcinoma to lymphomas. Lymphoproliferative, there are various types of lymphomas. Most frequent is the MALT, and you can see a mass here. They are usually B-cell non-Hodgkin's lymphoma, nicely molds around the structures rather than infiltrates and presses. Another important thing you need to know, the types of muscle enlargement in thyroid eye disease. Here is a patient treated for thyroid eye disease, but it didn't fit. So you can see that there is a thyroid eye disease. First muscle to enlarge usually is inferior rectus, followed by medial rectus, superior rectus, lateral rectus, usually in that order. But as you know, in medicine, nothing follows pattern, but usually it will be bilateral, usual pattern. This doesn't fit the usual pattern. So we did a biopsy of the external surface of the muscle and turned out to be quite an aggressive lymphoma. Here is another patient with a sebaceous gland carcinoma. Here is a patient what looks like a preseptal cellulitis and an abscess, but no, it wasn't. It was an aggressive lymphoma. Here is another patient with an aggressive lymphoma. Here is a patient with multiple myeloma with lesions around the orbit. Here is a patient with bilateral lesion, which looked like orbital cellulitis or preseptal cellulitis, but the scan gives it away. There is molding. He had bilateral lymphoma. Here is another patient with an aggressive lymphoma presenting as subacute with sudden proptosis. So obviously, lymphoma needs a biopsy, and newer molecular genetics technique have completely changed the way they're diagnosed. Here is another patient, very rare presentation. He had a sweat gland carcinoma secondary in the orbit. We never found the primary for him. So we looked at our lacrimal gland series and from 2 centers. And what we concluded was lid swelling and proptosis were the lymphoma series. We'll talk about lacrimal gland a little later. Proptosis were the commonest presentation. Bilateral disease, unfortunately, associated with systemic disease. Occurrence of systemic lymphoma seen in 11% of patients who presented with primary orbital lymphoma. Once diagnosis is established in our practice, we have an MDT for everything from soft tissue sarcomas to lymphomas to basal cell carcinoma, squamous cell carcinoma, head and neck team, lid cancer team, lymphoma team, sarcoma team. So they go to that team and they decide the management. We are more sort of technicians in basically doing a biopsy. Obviously, they are better placed to treat the patient than ourselves. Rarely in UK, an eye surgeon or orbital surgeon is involved in decision-making regarding treatment of conditions like lymphomas. Mesenchymal tumors, solitary fibrous tumors, a right term for hemangiopericytoma, very slow growing. And the other mesenchymal tumor in children is rhabdo. There are two peaks, age 3 and age 7, and we see this. Unfortunately, once or twice a year, we have patients with rhabdomyosarcoma, rarely other types of sarcomas. Here is a patient with a solitary fibrous tumor. They tend to bleed quite a bit during surgery, and it's almost impossible to excise it completely. So you need to be careful because they are adherent to the optic nerve, and the recurrence rate is quite high. Though it's advocated to remove it completely, it's next to impossible in our hands. Even if they have a good capsule, you're very careful when you're taking them out. Here is a child with a rhabdomyosarcoma. Secondaries can spread from structures around the orbit into the orbit. Unfortunately, they're present in the orbit. Here is a patient, fortunately turned out to be a mucocele. Here is the patient with poorly managed basal cell carcinoma spread into the orbit. When tumors spread into the orbit, they cause more cicatrization and enophthalmos from peripheral tumors spreading into the orbit, including breast carcinoma metastases, produce cicatrization rather than a proptosis. So here is a patient with a pagetoid spread of a sebaceous gland carcinoma into the orbit and ocular surface, needed an exentration. Here is an unfortunate child who presented with watery eyes and thought to be preseptal cellulitis, but turned out to be a nasopharyngeal carcinoma. They carry a very poor prognosis. Here is a patient with a unknown primary, but squamous cell carcinoma, which typically presents with cysts. If you see cysts in the orbit, think of squamous cell carcinoma. And we did a combined neurosurgical approach, and he did live a long time, and he died of a heart attack. Here is another patient with, unfortunately, a lacrimal sac squamous cell carcinoma presenting in the orbit. Here is an interesting patient who had a olfactory neuroblastoma presenting in the orbit and with watery eyes. This is the same patient. She's still here to tell the tale. Here is an unfortunate patient, again, with nasal symptoms and watery eyes, and turned out to be a nasopharyngeal carcinoma, and they carry a very poor prognosis. Here is a patient referred for watery eyes. Unfortunately, he had ethmoidal carcinoma presenting with proptosis and metastatic disease. Breast carcinoma, both as primary and secondary presentation in men. In women, men, it's lung carcinoma. And do not forget paraneoplastic. In many patients now, we do a total body PET scan when we can't find what's going on in spite of repeated biopsies. So we have found thyroid carcinoma in patients with orbital inflammation. We have found suprarenal carcinoma in patients with orbital inflammation. Lung carcinoma in patients with orbital inflammation. They are all paraneoplastic syndromes. Another paraneoplastic emerging now is all these biologics being used for treating other carcinomas in the body. They're present with uveitis, they're present with orbital inflammation. So be careful when you're treating these patients. Here is a patient, ptosis with the breast carcinoma secondary. Here is a primary presentation of a breast carcinoma. This patient, no history of breast carcinoma at all. You can see the right enophthalmos. We did multiple biopsies and found the breast carcinoma, and she was treated as inflammation for some time before she was referred to us. Here is another patient where I do some work in Chennai. This patient had bilateral, what was treated as idiopathic orbital inflammation with plenty of steroids. And when I saw her the first time, just retropulsion, push your hands against the globe. If it is rock hard, it is secondary in the orbit unless proven otherwise. So I got the girls to have a check her breast. Unfortunately, she had very advanced cicatrizing breast carcinoma with presentation in both the orbits of cicatricial changes, and I don't think she lived too long after that. Treatment options, obviously biopsy, staging, you need to do various types, and you need always MDT. There are so many people with different knowledge, skills in their specialties. We are just limited to the orbits and doing orbital surgery, but they are there, plenty of them with plenty of knowledge. Always MDT for everything and anything. So lacrimal gland could be epithelial or non-epithelial, malignant or non-malignant. We'll just present our series, go through very quickly. We have published one of the largest series of lacrimal gland tumors. You can find it in the eye journal if you put our names on it. So benign is considered pleomorphic adenoma, but can turn out to be neoplastic if left long enough. Malignant adenoid cystic carcinoma is and carcinoma and a pleomorphic adenoma are common tumors. So extrinsic could be inflammation, so you need to be careful when you diagnose. So we looked at all the patients in the recent series. This is a pictorial series which we published for CT and MRI, which is again well reviewed, and plenty of people write about it. So have a look at that pictorial review, which gives you an idea of what to look for. We have never made a mistake in a patient whom we thought had pleomorphic adenoma, and we have never did an incisional biopsy in a pleomorphic adenoma yet. So if you look at the patient carefully, if you look at the scans properly, if you look at their history, and if it's very unlikely that you will miss a pleomorphic adenoma and go in for an incisional biopsy. I will not bore you with too many details because I know there are dermoid is not uncommon in the lacrimal gland area. Here is a dermoid. not a lacrimal gland tumor. Here is a pleomorphic adenoma. Typical features in a malignancy, you do an excision biopsy. Non-typical, do whatever you want, but most important, 3% can get into malignant transformation of pleomorphic adenoma. So do not do incisional biopsy if you can. Adenoid cystic carcinoma is not that common, but we may be, in a practice like ours, we see 1 in 3 or 4 years. Not that common. So here is a patient with adenoid cystic carcinoma. Less than 6 months history, reduced ocular movements, neurological invasion. So you need to be very careful when dealing with these patients. They spread very quickly. Again, lot of controversy regarding managing adenoid cystic carcinoma. Our base of skull unit, which we use, tend to go for radical surgery. I know Beta Ismaili doesn't like radical surgery for this. She has the largest experience in dealing with orbital carcinomas in the world. Dacryoadenitis, we will not bore you with it, but be careful. Sometimes lymphoma and other hematological malignancies can present as dacryoadenitis. So we looked at all the lacrimal glands, and I will not just go to our series. So in our experience, we did 261 patients. So inflammatory was commonest, but look at lymphoma, second commonest, followed epithelial tumors as well, and other types of diseases. So in the lymphoma, you can see what is the commonest is the marginal zone lymphoma, but B cell, of course, and mantle carries a poorer prognosis than the rest. So we looked at all our pleomorphic adenomas were 6 and adenocarcinomas were 9. All of them, none of them were biopsied wrongly. Of the adenocarcinoma, so I will not bore you in the details, but occasionally granulomatous inflammation can present as lacrimal gland malignancy. We had a couple of Sjogren's, and the Sjogren's can turn out to lymphoma. So just because you had a previous diagnosis of inflammation doesn't mean it will continue to be inflammation. Anything which inflames in the orbit can become a lymphoma later. So we do have the occasional TB, and if they're combined with uveitis and the rest, then you need to think of autoimmune disease. And do not forget our friend IgG4 or IgG2. I will not again bore you in details of that. Everything is available on the net. IgG4 is overdiagnosed, we think, but the treatment is the same like any other idiopathic inflammation, steroids, non-steroidals, and be careful, they could again turn into lymphomas. So the various types of treatments available for all the patients. So always use an MDT. And any systemic disease can present in the lacrimal gland as an inflammation or in the orbit as inflammation. So inflammation in the orbit doesn't mean it's just inflammation. There could be paraneoplastic syndrome. So you should have very low threshold for biopsying, scanning, revisiting diagnosis, restarting your process from the beginning again, forgetting whatever has happened so far. So we have missed so many patients because we didn't thoroughly investigate them with PET scan. Now we do more often, we use PET scan than ever before. So anything, do a biopsy. And we do open sky. We don't believe in doing needle biopsy. They don't respond to steroid, re-biopsy. Keep repeating biopsies if necessary. And looking at our exentration series, another interesting finding which we have published in the Orbit Journal, non-orbital other malignant conditions in the body is more common in patients who had exentration than otherwise. In our series, you can see unrelated primary, cervical carcinoma, melanoma, renal carcinoma, colonic carcinoma, rectal carcinoma, polycythemia. So just because you have removed the tumor exentration completely excised doesn't mean these patients will not get tumors elsewhere. Maybe they are prone for this. That's why the tumor has spread quickly in the orbit. That's why you had to do an exentration. So exenterated patients have more tumors elsewhere in the body. So these are all some of the patients we have exenterated in the past. And as I told, we have very low threshold for doing CT, PET CT in patients whom we find just inflammation in the orbit. Do not forget all the wonderful new drugs. And again, you involve your MDT. So in conclusion, I would like to conclude that every patient needs thorough investigation, repeat biopsies, and always involve the MDT. They have fantastic skills available from all specialties. There are so many new treatments emerging. I've just given a bird's eye view of orbital tumors. Again, I would like to emphasize MDT. I know in certain many countries, people tend to work in their own specialty type hospitals rather than in a large hospital. NHS, we are very lucky. We usually work in a very large hospital with multiple specialties available. So we have access to all the departments. But again, you need to get that access if you're a sole private practitioner or practice in your own group of ophthalmologists. And there are so many newer treatments emerging. As I said, do not hesitate to re-biopsy and revisit. Orbital surgeon role these days, I keep telling, has mostly become a technician these days. I would like to finish with that. Thank you all. Thank you, Sendil, for having me on this fantastic teaching session. Thank you.
Thank you. Thank you, Dr. Sampath, for the excellent presentation. Just to show the vast experience which you have in dealing with orbit cases for the last maybe 30 years. Thank you so much for sharing your experience. Does the panel have any questions for Dr. Sampath, please?
Thank you.
Excellent.
Yeah. Okay. Yes, ma'am. Please go ahead, ma'am.
Yeah, I think it's an excellent presentation. I think an overview. Impossible to keep it so concise, and he's covered almost everything possible. The only thing I wanted to just add and remember, especially in our context, tuberculous bacteroideinitis, which we ought to keep in mind. And as he was mentioning time again, that what is initially inflammatory need not be an everlasting inflammation. It could transition. So we need to remember that we can do multiple biopsies, because often we get disturbed and frustrated. And as beginners, sometimes you feel that you're very discouraged to do repeated biopsies. But I think even experienced surgeons like Dr. Raghavan sir is having situations where he had to repeatedly biopsy to prove the diagnosis. I think all of us should remember that it's pertinent that we continue to investigate and not give up easily.
And if I'm allowed to comment, we have 4 lid lacrimal orbit surgeons in our unit. We are all very busy. We share our patients, we share our knowledge, we learn from each other. Teamwork is great. So Joyce is a wonderful colleague. So is Antonella and Mary, who's going to hopefully join us soon on a substantive basis. So, and we have very good fellows and trainees. And when a trainee asks a question, it doesn't mean he's asking. It's very, very useful for us to top up our knowledge, because they are very good in. They're all bees. They spread the pollen everywhere. So we need to learn from juniors, learn from colleagues, learn from other specialties. Orbit is fascinating. Anybody wants to take up orbits? It's really a fascinating field. Thank you.
Thank you. Thank you so much, Dr. Sampath. And like ma'am said, I think it's a vast topic, and you beautifully actually concise it. I had a small question actually. In patients, more or less, I saw that a lot of CT scan has been advised in most of the orbit cases. So let's say you see a very vascular lesion. Would you like to go in and send it to your intervention radiologist, embolize it and then remove it? And if yes, then what would be the period
vascular
between
lesion
the
these days? We hardly operate on vascular lesions. We send them to neurovascular radiologists, so who deal with them. I haven't done a vascular. When I started my life, I used to operate on vascular lesions. Now we send them to neurovascular radiologists. If they are kids, they go to a specialist in London. If they are adults, we send them to local neurovascular radiologists.
Right. And regarding SFT, as you mentioned, would there be any cutoff? I think that's a very interesting hot topic that we have, solitary fibrous tumor. On histopathology, what would be your cutoff to give any post-operative radiation or any
Again, as I told you, we are in the UK, at least we surgeons have become mainly technicians. So MDT will decide. So that for people with SFT is obviously more common in the lungs than on the pleura, than in the orbit. So they go to the sarcoma MDT. We have a special it's called soft tissue MDT. So it goes to soft tissue MDT, and soft tissue MDT decides based on the histopathology what treatment needs to be given. So I am not very up to date because I depend on them to decide.
Right. Okay.
Sorry.
No, that's absolutely fine. Yes, ma'am.
I think Dr. Sampath sir is way too lucky to have this team. We are not. So I think we'll have to work around ways to make sure that we are completely on top of these
Yes. So here, I think we
cases.
collect
So I think,
all literature, and we push our MDT to say that, this is what is given in literature and this is what we need to do. So our cutoff is basically anything more than 4 mitotic this thing per HPF for solitary fibrous tumors. Then only we'll start and give radiation or any other immunotherapy. But having said that,
you are all very lucky as youngsters. You have all the information in a little phone. Whereas when I started my life, I had to go to the British Library in Holborn Street to look at all the publications. That's one library in the world which has every English medical publication available. So you're all very lucky. Then we had the CDs. We used to go to, I think, RSM to look into the Medline CD it was. Now all of us have just simple access. Fantastic.
yes.
but
Thank you.
I think with your experience, I think you should, with the team involved, I think you can give us some reports on how it fares with solitary tumors, fibrous tumors. You can probably throw some light on
Right.
the outcomes.
I will, if you are interested, I will ask the sarcoma or soft tissue group to see whether they will be happy to give advice on your solitary fibrous tumors.
And one more question to you, sir, is have you been the first to identify leukemic cases? Because we see a lot of granulocytic
Yes, we have
sarcoma.
actually, we have published a series of 4 kids who presented with what looked like orbital cellulitis. And then we did a biopsy and turned out to be leukemia. So no, we have published a series. Have a look. There are only 4 patients though, a while ago.
But over here, what had happened is in a recent case of mine, when we initially started doing biopsies of the granulocytic sarcomas, the hemato-oncologists were very unhappy. They said, why don't you just refer to us after a peripheral smear and a bone marrow if possible? We would do the rest. But in one of my cases, I found out that the peripheral smear as well as the bone marrow biopsy turned out to be normal. But then we had to go and do a biopsy. So is that the scenario in your...
No, what we tend to do is, if the patient presents with an orbital lesion, they always get a battery of blood tests. We never do a biopsy without a battery of blood tests. And if the blood tests show an abnormality, then we discuss with the particular specialty to decide whether they need an orbital biopsy, whether that is enough what they have got. Number 1. Number 2, we learn lessons from every patient. So we had a patient many years ago, which I talk in all the meetings which I go to, a child on the pediatric ward. I don't know whether I'm exceeding time with the discussion. Sorry. Pediatric ward admitted with chest with sinusitis, ear abscess, drained, sinusitis treated, presented with a preseptal cellulitis and a lid abscess. I saw the patient on a Tuesday morning, took the patient to theater Tuesday afternoon, requested all the bloods. By then, the patient has had 2 GAs before, so we thought maybe the bloods were all okay. So we drained the orbital abscess. Next day, the child was getting better. Third day, the child wasn't getting better. So then we looked at all the bloods. Unfortunately, around 10 blood tests done, all have been reported as clotted samples. Okay. And the child started deteriorating. So we got hold of the pediatric intervention from the intensive care, who rang me at 1 a.m. in the morning to say this child has myeloblastic leukemia.
Oh.
So never underestimate. So we always go for CRP and blood tests before we go to theater. Now I make sure I look at the blood tests myself. We all make the mistake. We all run a busy service. We depend on so many people. So sometimes the system lets us down. We have to be very careful when you're dealing with an orbit. There are lessons to be learned from every patient.
Yes,
Well,
that's
thank
true.
you. Thank you, Dr.
All right,
Sampath. Thank you, panel, for the excellent discussion. And it's always a pleasure hearing Dr. Sampath speak and share his vast experience with us. Thank you once again. And I think the next speaker is supposed to be Dr. Gangadhar, but Don, do you want to speak right now?
Oh, I thought I was on the schedule for next.
Ganga, is it okay if Don finishes his talk?
The star always goes first.
Yeah, yeah, okay,
No,
thank you,
no.
thank you.
On the schedule I
Don,
received,
that's
I
fine,
was
yeah,
next. So I'm
yeah,
sorry.
yeah, yeah. Dr. Don, we have great pleasure in welcoming Dr. Don Kikawa, who is a distinguished professor and the Trude Khan Hollander Endowed Chair of Ophthalmology at the UC San Diego in California. He is also the Division Chief of Oculofacial Plastic and Reconstructive Surgery and the Distinguished Professor of Plastic Surgery at the UC San Diego. It's a pleasure to welcome Dr. Don Kikawa with us. And you can start your talk, Dr. Don. He's going
Yes,
to speak
thank
to us
you.
on orbital trauma, current concepts.
Thank you for inviting me to speak at this masterclass. It's an honor to be here. And the version of the schedule I had me after Sampath. So I'm sorry, Ganga, if I introduced myself before. Let's see. This is a talk on orbital trauma. And in 12 minutes, what I thought I would focus on would be the implants that we use to reconstruct the trauma. Like intraocular lens implants, we've all seen a vast improvement in technology. And there's a trend from one size fits all to a custom specific, patient specific implant. Many materials have been used and described for orbital reconstruction. And I think rather than focus on the choice of material, we should focus on the position and location, which is far more important than the material used. So I thought to kind of categorize this talk, I kind of thought we would look at versions of orbital reconstruction, almost like versions of software that get introduced. So version 1 is a sheet type implant. Version 2 would be a prefabricated implant that the surgeon can still modify. Version 3 is a patient specific implant. And version 4, I think, is still to be determined. What will the future entail? So version 1.0 is a sheet type implant. It's a two-dimensional object of various material. It can be made of MedPore, Supramid, Teflon, silicone, titanium. And these are fabricated in the operating room based on what the surgeon perceives as the size of the defect. It's molded by shape. It can be cut with large scissors into the appropriate size. But the most important thing is to remove all the prolapsed tissue. These are primarily either medial, wall, or floor fractures. Remove all the material and place the implant to cover the hole. And the principle is quite simple. It's like a manhole cover, but the cover has to be supported on all sides of the hole, otherwise it may tip into the hole. In the orbit, we have specific bony ledges that we place the implant on. Posteriorly, the most important one is the palatine bone, as depicted here with this yellow arrow. You can see the ledge of the implant, and this should rest on that bony support. If you don't have that support, you might get downward tipping of the implant, and then you get recurrence of the problem. So try to keep your implant rigidly supported by bony ledges on all aspects circumferentially. What we do intraoperatively, we check force ductions to make sure there are no entrapment of the muscles, make sure the globe moves freely, check for bony globe position and symmetry to make sure that there's an equal amount of globe prominence on each side. This happens to be a patient that was referred to me with implant malposition. So if you can look at the primary photo on the top, you see this patient has enophthalmos, hypoglobus, deep superior sulcus. Motility is not bad, so there's no evidence that there's any muscle entrapment. However, what this postoperative scan depicts is that the implant is in bad position. The anterior portion appears to be okay, but the posterior ledge is not resting up against that posterior support that we talked about. It's possible that this implant could have displaced, but more likely this implant was not placed in the proper position with the original surgery. So the options for dealing with this could be to remove the implant, start from scratch, start over. Probably stacking of an implant on top of this one would not be a good idea because you would have to get all this tissue up into the orbit and then you would place an implant on top of that and then you'd have this dead space to deal with. So we opted to proceed with removal of the implant. This here shows an old titanium implant. All the hardware came out, and then we're left with a very large hole that was reconstructed with another sheet covering all circumferentially the bony ledges. Here's the patient pre-op on left, on the table, showing improvement of the globe position, and then here's the patient before and after reconstruction on the bottom. So version 2 are prefabricated stock implants, and I'm sure you've all seen these types of implants that are prefabricated, and you can order either right or left variant, and then these can be shaped into configuration based on the size and extent of the defect. So this is a gentleman who unfortunately lost his eye and had some bony trauma after a explosion. You can see his inferior orbit has been fractured. He's missing some bone along his inferolateral rim. This is very clearly seen on the clinical photo. And what we elected for in this patient was there's a stock 2/3 orbit that is produced. This is a standard orbital configuration. Obviously, we've never put anything this large into an orbit, but what it does enable the surgeon to do is mold and shape the needed implant from a stock implant. So even though this was the size of the stock implant, we actually only ended up using this portion of the rim. You can see here on the bottom right, this is the size and the titanium plates that we use to fixate the implant. So this is the patient before and after. We filled in this bony defect with MedPore. We also were able to reconstruct his eyelids and socket, and here he is with the prosthesis postoperatively. Not an ideal result, but certainly a good functional result in this patient with severe trauma. So version 3 with implants is the patient-specific implant. So these are prefabricated. There's 3D modeling based on the normal side, which is mirrored to the side with the defect, and then a cast molded implant is then made based on the difference in shape from the defect to the normal side. So indications for this type of implant: any sort of combined rim and wall defects, complicated reoperations, and then patients certainly need to probably have some significant globe displacement to start with, either hypoglobus, and then areas where traditional implants may not be adequate to fully reconstruct the defect. So this is an example of a PSI that's made on the right orbit. So what is done is a mirror image is taken from the left side, flipped over to the right, and then there's going to be a net deficit of the normal configuration, which is this upper red mark, based on what the defect would be on the normal side versus the actual defect. And then the implant gets fabricated based on the difference between these two. So this is the 2-dimensional scan. This is what the implant would look like on 3-dimension, and this is the implant after it's been fabricated. These are some other examples of patient-specific implants, and you can see the shape and size is quite different. These are 2 different ones, and it's really based again on the mirror normal side being interposed on the defect side, and then an implant is made appropriately. So let's look at a couple cases of where a PSI was useful. This is a patient who had previous trauma from a motor vehicle accident. He has had previous surgery. You can see his right eye is displaced downward. He actually has a little bit of enophthalmos. He has a little bit of superior sulcus defect. Here's his 2-dimensional imaging. You can see here's the previous implant. And then based on the cross-sectional area of the coronal view, you can see that the right orbit is still expanded. If you look at this enlarged cross-section compared to this side, there is a net orbital volume gain, which leads to the enophthalmos and hypoglobus. So we elected to proceed with a patient-specific implant. This is the mirrored image from the left orbit to the right. This is the size and shape of the implant. Some of these implants are difficult to place into the orbit. So when we either proceed with the transconjunctival dissection, we do need to maybe consider splitting the implant. We can cut these and then put them in two pieces and then bring them back together once they're in situ. So this is the patient pre and post reconstruction. You can see his hypoglobus is corrected. We're also able to fill in his superior sulcus. Case 2 is another patient that we elected to proceed with the PSI. Here he is after undergoing, again, a car accident with a severe trauma to both sides. So he came in with orbital implants, one here located on the right. This is his left orbit. And again, on cross section, you can see the orbital diameter and volume is much expanded on the left side compared to the right. We felt the right side was in decent position, and even though maybe it's not ideal with its placement, we elected to concentrate on the left side because the left had the greater degree of functional impairment as well as the deep superior sulcus and enophthalmos. So this is the size and shape of the PSI that we created for this patient. Again, and this is an interesting case because we're taking a traumatized, previously operated on mirror to flip. And most of the time, these patients have only one orbit involved. But in the case of a bilateral fracture, you kind of have to figure out where you want to put the new orbit. So this is a mirror image of where we thought the left orbit should be. This is the PSI that was fabricated. And this is the patient before and after surgery. We also fixed his ptosis so that makes the right eye look more symmetric to the left. But you can see the improvement in volume in the left. The brows came down after he had his ptosis fixed. And that's his before and after result. So where do we go from here? What does the future hold? I think in general, there's going to be a trend towards autologous tissues. I think these large alloplastic implants probably are not going to be what we do 30 or 40 years from now. There is biomatrix scaffolding that can be produced using 3D printing, and then we can use the patient's own autologous tissues to fabricate implants. So in my opinion, in the future, this is one stepping stone towards a totally autologous implant. So in summary, we've seen some large advances in orbital implants for reconstruction. The traditional techniques, version 1, I believe, is still used in the vast majority of cases with good results. Probably 75–80% of surgery is still done that way. Custom PSIs are available for complex reconstruction. However, they do take some time to procure and fabricate, and they are more costly than the standard materials. But certainly in good cases, in cases with severe trauma, there can be good results. So thank you very much. I'll take any questions.
Thank you. Thank you, Dr. Don, for the excellent presentation. Very eye-opening to hear your talk. And I invite the panel for any questions. Dr. Sonam, you're on mute.
Yeah, hi. Dr. Don, that is, I think, fantastic, lovely outcomes, especially in that one patient wherein you reconstructed the lids as well as you put in CMP. I wanted to ask you, like, what would be the thickness of the PSI that you are able to achieve? Because sometimes the initial PSIs that we tried were quite thick, but now with the latest things, I think we're able to get 0.67, 0.65 millimeters as well. So I wanted to know your experience with that.
Yeah, that's a good question. I think thinner is better. I think sometimes the engineers that fabricate these don't have any idea how hard it is to get larger implants in. And certainly the configuration of the orbit next to the orbital soft tissues is the most important. So I think the thinner the better, in my opinion. I think probably under 4 or 5 millimeters is ideal. Anything larger than that, they become very difficult to place.
That's correct. And also, I see that you've done a lot of secondaries recon. So how do you manage the soft tissue loss, the volume augmentation post
Yeah,
that?
there is going to be some natural atrophy of the tissues. Any patient that's had multiple trauma or multiple procedures, there's going to be some fat loss. So I think sometimes I've even done fat grafting, either liposuction fat transfer taken from other areas of the body that is harvested by small cannulas, and you can inject fairly safely. I mean, I wouldn't say it's totally benign procedure, but if with using good technique, site injection of cannulas and retrograde injection, I think you can help with the anaphthalamus. Also, I think people have written up using hyaluronic acid fillers in those cases. So I think those are two options for fat loss.
All right. Thank you. Thank you so much.
Yeah. Dr. Sampath, do you have any comments to make on this?
I don't think we can improve on Don's fantastic work. He's well known in the field. And thank you, Don, for agreeing to come non-human hours onto this meeting.
Thank you.
Same with Ganga as well. So other end of the spectrum with the time. Excellent. So we in our PSI, I think it's we concentrate more on the shape of the PSI rather than they get it as thin as possible. I think orienting the implant to the shape of the other side seems to play an important role. Say compared to a MedPore implant, which comes with the same shape with every patient. Would you agree with that?
Yeah, I agree. I think the interesting one that I showed at the end was where there was bilateral fracture. So where the normal position is kind of questionable, but I agree. I think thinner the better. Even the large ones, I don't know if you use transconjunctival approach or transcutaneous, they're hard to get in. And so I think, have you ever split them into two pieces? I think with the MedPore, it's easy to split. You cut it and then you can put it in two pieces.
We almost always do a canthotomy, cantolysis, and release the lid and do a swinging lid flap through the posterior approach. Having burnt our fingers with tarsal fractures, trying to stretch the lid and putting the implant in through the posterior approach, we have managed to fracture the tarsal plate bang in the middle. So we do a canthotomy, cantolysis now routinely when we put the implant in through the floor.
We do split them, and what we've what we started doing is we have a guide that we place on the STL model first and then position it. Then the guide is also titanium, so the guide already has prefabricated holes in it.
Drill
So
holes.
once you have that, we just put the hole so we know exactly where the implant has to be, because sometimes what happens is there's a lot of callus formation. So especially when we're doing the rim, that becomes a little challenging and we might have a little difficulty there and we may not get the exact position. So now we've done like 4 to 5 cases with the guide and our outcomes are much better than the ones that we did without the guide. So yes, that is.
Yeah. We usually get I don't know if you get a sterilized skull as part of your PSI package, but we get the skull and we can make sure that we kind of bring that next to the patient, so we might make sure we fit it exactly how it is inside too. But I've used the drill hole guides also, and I think that is useful. Yeah.
Yeah. Thank you, Dr. Don. I have one last question for you. What material is your PSI made up of?
These are MedPore, but they also come in PEEK as well as titanium, I believe. Those are the three that I've seen. I like MedPore because I think you can trim it a little easier, and at least the fixation is better. So, but that doesn't mean the other. Again, I'm going to say this again. Location is more important than material.
Okay. And how do you fix the implant when you use a MedPore? Do you have a prefabricated drill hole there, or?
No, it's usually a single fixation point. If we split it into two, sometimes you have to put 2 screws in, but you can screw directly into the MedPore.
Into the MedPore, is it? Okay.
Yes.
So thank you so much. Thank you again for sparing your time and coming at such an odd hour to take part in the meeting. It's always a pleasure.
Thank you very much.
Thank you very much. Yeah. So I'd like to invite the next speaker, who's going to be Dr. Gangadhar Sundar. Dr. Gangadhar Sundar is a senior consultant at the Department of Ophthalmology, National University Hospital. He heads the Department of Oculoplastics at the NUH. He is also an adjunct associate professor, Department of Ophthalmology at the Llewellyn School of Medicine, National University of Singapore. He is a past president of the APOTS and is a very, very popular speaker in the Asia Pacific region. He runs a hugely successful fellowship program at the National University Hospital and has trained a large number of fellows across the world. Thank you, Dr. Gangadhar, for taking part, and we welcome you to speak on aesthetic oculofacial procedures. Dr. Gangadhar, please.
Thank you, Senthil. Can you see my slide?
Yeah, we can see your slides.
And hear me. Good. A warm greetings from Singapore to Dr. Sujata. Congratulations on being the president, and Sampath and Senthil for putting this wonderful course. Truly a masterclass. Great talks, including Sampath and Joyce and Vanessa, and of course the great Dawn, the big Dawn, from whom we have learned a lot from. So it's my turn to share our perspective on aesthetic oculofacial procedures. I thought I'll just give an overview, depending on who the crowd is, the residents, fellows, or general ophthalmologists, to give an overview of the spectrum of work that we do. And I bring you greetings from the various societies I'm part of. So when you talk about beauty, beauty is actually very subjective, and I'll probably let each one of you read this for yourself. Hence, there's no single definition of what aesthetic surgery and aesthetic outcome, an ideal aesthetic outcome should be. It is not just a physical thing, it's an emotional concept as well. And of course, there are huge cultural variations. When you look at an individual person as such, it's about symmetry and harmony. So coming from South India, the beautiful temples you have over here, it's all about symmetry and harmony, which is what things make it beautiful. And naturally, young is beautiful. And that's the reason why the older patients who are coming for procedures are actually asking for rejuvenation. They're not wanting to look like anybody else. They just want to look at as though they were much younger when they were much younger. As opposed to a younger person seeking aesthetic surgery, they actually want a better harmonization and a true beautification where they are trying to slightly change the way they are at this point of time. So these are my disclosures, and this bring you greetings from my team with whom I have worked with and I learn a lot from. So in the next 10 minutes or so, I'm going to talk about aging as such, the clinical features and assessment, what are the minimally invasive procedures that we have, the invasive surgical procedures, and finally, and most importantly, complications that come from this as well. Aesthetics is becoming a popular topic, not just among physicians and practitioners, but actually the patients themselves are becoming more aware. People are living longer, they're much healthier, they're being productive, they continue to be serving in the profession and boards and meetings and traveling much, much longer. So gone are the days where a 50, 60, 70-year-old thought he or she were old, but they are seeking a lot of these rejuvenative procedures. And there are numerous things which really cause aging. Some of them are non-modifiable, genetics, ethnicity, gravitational changes, for example. But what you see in the bottom right over there are all modifiable risk factors. It's been shown that once you hit 30 is when you really have to start taking care of yourself to really prevent the consequences of severe aging changes as time goes by. And if you want to look at how you will be when you're going older, you just have to look at your parents and you know what happens. You start looking at your parents, a combination of your father and your mother and your uncle and your aunt and so on and so forth. And a lot of changes happen because of deflation, skeletal changes, dynamic changes, which is what we'll talk about. And there are huge ethnic variations as well. In a way, pigments protects a lot of the sun-related aging as well. So when people going for lighter and lighter skin, they don't realize the consequences that they're going to have. Abuse of substances, tobacco and alcohol. Thankfully, a lot of countries are going gung-ho and banning a lot of these substances in young children by the time they pick it up. But all of that also predisposed to a lot of aging changes. Sun exposure, again, reasonable sun exposure is very good, but prolonged sun exposure, sun worshipping any form also causes significant skin-related changes. What makes a baby look cute? The fat dispersion and spread of the face, and which is what we lose, like an orange which is dried up, and you start seeing the wrinkles on the face as well. We think this is a concept of the past, but now you realize that just as how during HIV/AIDS pandemic, I mean, when the whole world was, we saw a lot of facial hypertrophy. We now know that these new weight loss programs are also predisposing to a lot of premature aging, hence resulting in more aesthetic procedures going to be performed on these patients. Genetics, we talked about how you will look like, how your parents look old. And of course, excessive facial reanimation also leads to a lot of brow ptosis, dynamic and initially dynamic and eventually static rhytides. To recap, I think aging changes happen everywhere from the top, including losing the hair, to a tall forehead, to brows descent, gravitational changes in the mid-face, the neck, so on and so forth. Underlying bony changes happen, and with overlying skin and subcutaneous fat changes as well. So what's the big deal? The big deal is that it results in a lot of miscues. So a patient who's actually pretty young, youthful, energetic at the workplace because of the droopy eyelid appearance and the sagging, they convey a message of either anger, distrust, hate, or even tired and sleepiness as well. So bottom line is people don't mind growing older, just that they don't want to look it and they want to see a younger version of yourself. So we're looking at what are the principles behind which you're going to be managing them, what are the modalities we have. We go to the sixth principle of 6 hours, where we relax the muscles with keynote denervation. Where there are hollows and deformities, we refill them with various forms of tissue fillers. When the skin changes are present, we can resurface them with lasers or chemical peels. We can restore subcutaneous tissue tightness with radiofrequency devices. And finally, of course, when everything is sagging down below, you have to raise, replace, and fixate it, and that's resulting in total rejuvenation. And you think of the assessment of the patient not just from the history and comorbidities alone, but assess them in layers. And I talk about it as a 4D assessment because 3D assessment is a physical assessment. The fourth dimension is the emotional concept of this patient. What is the real motivating factor? What are the goals here? Do they have realistic expectations? And make sure you don't touch a patient who's got body dysmorphic disorder. So if you're really assessing a patient, you have to assess them from head to toe, apart from the history taking, so on and so forth. You can classify them into the upper phase, the mid phase, the lower phase, so on and so forth, all from superficial to deep. So if you're planning treatment for these patients, yes, you don't have to touch a lot of these patients. Make sure they are motivated, if they're willing to accept what they are, because sometimes patients wonder, why me? But if they look at the people around them, if it matches with the age, they don't have to do much. Versus a lot of patients where we're actually now going more and more to minimally invasive procedures, typically for the dynamic rigidity with chemo denervation. But every once in a while, you have to be a sartorial, you have to have sartorial skills, become a tailor. You have to learn to cut and fix, but never ever offer surgery the first go itself. Make sure you see them again. So you see them multiple times, understand the personality behind, and keep a very low threshold in a patient who is doubting you to ensure they get a second additional opinion self. So these are the principles that we're going to be talking about. Rigidity, whether static rigidity or dynamic rigidity, this deflation, how you're going to augment soft tissues, and as true descent, we're going to talk about lifting and surgery itself. This is one of the most commonly performed procedures, aesthetic procedures, anywhere from top to bottom or the face itself. Started off with us skilled people doing it. Now even less skilled GPs and family practitioners starting to do it as well. Remember, they have both functional and aesthetic benefits to these patients, and it does now part of the armamentarium to the rest of the stuff that we do. There are different brand names available. I don't have any conflicts of any of these itself, but make sure you use one commonly, frequently, know the strengths, limitations, concentrations, so that you're able to deliver. And every once in a while, you form antibodies to one of them, then you can go to the other one itself. These are common indications of static rigidities or dynamic rigidities that you see, which can be used for functional and aesthetic procedures. Examples of before and after treatment. But as in any other thing where you're talking about intervention, remember complications. You can induce an iatrogenic facial palsy, which is oftentimes irreversible. You have to wait for the botulinum toxin effect to run out. Under treatment is an acceptable complication. You can always retreat the patients. But things like ptosis and diplopia can be quite disabling. So when do we use tissue fillers? When there are true hollows on the face, very similar to filling up potholes on the roads itself, where you're basically filling up the subcutaneous tissues. Various materials are available. It has gone from synthetic devices to autologous fat, and that's now the current popular one. And they can be classified into temporary, semi-permanent, and permanent ones. We have moved away completely from permanent tissue fillers for these patients. They're classically used for periocular rejuvenation, including the tear trough deformities, nasolabial folds, total facial volumization, where fat or autologous or synthetic fillers can be used. And a lot of times we do use it as a touch-up post-blepharoplasty for asymmetries itself. But this is even more dreadful compared to other injections because you can cause vascular occlusion. Skin necrosis is not uncommon if you're not being careful. Blindness is a real complication. It's a random event that happens, partly technique related and sometimes technique independent as well. So make sure if you're an injector, make sure you have an emergency trolley and make sure you do have a network for referral for these to help the patient first and also protect yourself medically. Long-term fillers can also cause granulomas, and now there's a description of a pillow face where you have filled up faces with these problems. But when you go to surgery, then that's when you talk about brow lifts, blepharoplasties, and mid-face lifts, and you have to think with a knife. Here's a patient who's referred for dermatochalasis. You look at the upper lower lids and say, I'm going to do a blepharoplasty. But evaluate the patient as a whole, you realize her brows is actually below the rims. You can see the mid-face sags, and that's where the brow lifts and blepharoplasty really comes in. So these are patients who are classic examples where it's occluding the visual field. So there's functional deformities. At the same time, they have to put a lot of frontalis effort to keep their eyes open with a lot of social miscues that happen itself. So traditional upper blepharoplasty is one of the most commonly performed, very satisfying procedure with the skin reduction, conservative fat excision when it's appropriate, keep the orbicularis, and go ahead, reform the crease if the creases is lost, so that you're able to get good rejuvenation, as you can see with a simple half-an-hour procedure. But when you're doing upper blepharoplasties, you have to make sure that if there's an associated ptosis to address it, address lateral hooding, and if when you can avoid a surgical blepharoplasty, you can use chemical brow lifts that actually can relieve a lot of this hooding of the upper lid skin. But when you think of the upper eyelids, do not ignore the lower eyelid. These are almost always cosmetic, because upper blepharoplasties can be either medical or cosmetic itself. And there's a continuum to the midface. And remember the various fat pockets which do herniate and prolapse. In the past, we were quite aggressive with resection a lot of these fat. We were going through a lot of transcutaneous approaches. Nowadays, we do a lot of transconjunctival approaches. We've gone away from aggressive fat resection to now fat transposition, fat restoration. The one fat pad you really want to exercise is the lateral fat pad, which can be sometimes annoying when you think you've done a good blepharoplasty with a little residual bulge laterally itself. So Sam Hamra has propounded this, and that's become very popular. But again, you have to selectively use in your patients about fat transpositions. Again, along with blepharoplasty come complications itself. So you have to be aware of it. Try what you can to prevent it and minimize it as much as you can. A lot of hand-holding for these patients. But as we talked about, it's beyond the upper and lower eyelids, and that's where brow ptosis and mid-face ptosis has been. Here's an example of a patient where the marking is literally on the superior orbital rim. You can see how the brows have descended, and you can see the bunny lines that you have. That's a classic example of a brow ptosis. And if the curtain rod and a curtain has come down, you have to reposition the rod, and that's a principle of a brow lift itself. The various ways of doing it, and we have doing it, and depending on the indication itself. So you have to be versatile with multiple techniques and tailor it to the patient rather than one size fits all. So you have to assess the brows, how sparse or how dense eyebrow is, how much of a hairline do they have, what is the contour of the brow, how mobile are the brows, associated dermatochalasis, the true or pseudo dermatochalasis, so on and so forth. The workhorse of all brow lift procedures is a direct or supra brow lift, where there's almost a one-to-one elevation with the amount of skin excision that you form. And the principle here is always excision is a form of fixation. Here's an example of a patient who's had direct supra brow lift, sparse hair, but you can see a barely visible scar, which does get better as time goes by. No blepharoplasty done for this patient. So value of a nice, well done supra brow lift. The gold standard has always been the coronal brow lift, where we do it occasionally in patients with severe upper facial descent, where it's a staged procedure where we go through a large coronal incision, almost always under general anesthesia, whereby in a staged reconstruction, we've done the upper part of the face rejuvenation first. Then a second stage procedure, we've done an upper lid and the lower lid procedure itself, so that you're able to get a total rejuvenation of this patient. Exceptionally, we do a mid-forehead lift where you cannot hide scars anywhere, and they have deep rhytides. The only downside, as you can see in the picture right, where you do have a visible scar. So wound healing is very important for these patients. And of course, there are keyhole procedures, which used to be quite popular. We used to do a lot of it with endoscopic guided procedures, but nowadays they're able to do it without an endoscope and able to fixate these structures through bone tunnels centrally in the deep temporal fascia temporally itself. Finally, wrapping up on midfacial ptosis, when you do lower lid blepharoplasties, you have to address midfacial ptosis. Remember, there's orbicularis row, true lower lid dermatochalasis, and malar festoons, and malar festoons are hard to manage. You have to learn various approaches and tailor it to the patient depending on what your indications are. You can do various forms of plication, spasmectomy, fat injections, but now with all the autologous fat, we are now actually refilling the face and resecting skin much less than what it was done before, but still has a big role in midfacial rejuvenation. These are examples of pre and post-ops. Like any procedure, you have to be aware any surgery has a potential risk of death and blindness, in addition to which a whole lot of other complications. So in summary, aesthetic oculofacial procedure is a wide spectrum of procedures. As a surgeon, you have to be quite familiar with the indications, the contraindications, techniques, and most importantly, minimize techniques. Those who are beginners, apart from doing a basic reading, don't watch YouTube and start practicing these. Go watch experts, join yourself in cadaver dissection courses. Familiarize yourself with the principles and approaches in surgical planes and functional patients first, before you touch a true aesthetic patient. Choose a patient with realistic, relatively low expectations. Deliver the results that build your skill as you go along as well. And finally, of course, if you're really scared of complications, you really want to avoid complication, there's a one very easy solution for you all. Do not operate. So thank you very much. And I'd like to actually just put in a word for 3 important meetings that are happening. There's going to be a 3-day dedicated meeting for dacryology in Estonia in June. I welcome you on behalf of the ISDDE. We are organizing a 4-day meeting on orbit oncology and thyroid eye disease in Singapore next October. And finally, the Asia Pacific Ophthalmic Trauma Conference right at the top of the world in Kathmandu next year. Thank you very much.
Thank you, Dr. Ganga. Thank you for the excellent talk. Always a pleasure hearing you and learning from you. Does a panel have any questions for Dr. Ganga, please?
Sendil?
Yes,
Sendil?
yeah.
I've listened to almost all the talks as I was traveling to the airport, and it was really fascinating and fabulous. I really thank all the speakers for sparing their time, and I can see the amount of expertise that they've gained over the past few years that they have been practicing. I mean, really, we are very, very blessed, and I think TNOA is really very happy to have these wonderful speakers and the panelists today. Thank you, and most importantly, I think we finished on time. That is very important.
Thank you. Again, like to thank all our international speakers for taking time off. We all know you're extremely busy, and very thankful for you for taking time off and participating in this TNOA meeting. I'd also like to thank our president, Dr. Sujata Mohan, who's actually flying to Dubai. She's talking from the airport lounge, which shows her dedication. A cornea specialist sitting till the end of an oculoplastic meeting is something, a very rare sight which we don't get to see.
I would like to add, corneas will not survive without a blinking lid.
Yes.
Most of the times, the cornea suffers because of the lid surgeon. May I say that?
So we are giving you more work.
Okay.
I tell all my postgraduates and juniors, the most important part of the eye and the most important specialty is oculoplastics. If the lids don't blink, if the tears don't spread, cornea will not survive. Thank you.
Thank you.
Nobody
Thank you,
can beat you.
I'd like to again thank all the panelists as well, and for obliging and taking part, staying till then. Thank you, Yogi Madam. Thank you, Sonam, Pratibha, and Usha Kim, especially, who was joined from Egypt. She's on a wedding there. She's taken time off to participate. Thank you all again, and looking forward to inviting again all of you for the next meeting. Thank you all. Thank you very much, and have a good
Thank you so
day.
much. Thank you.
Bye.
Bye.